Prior to proceeding with this video, please complete the corresponding survey and test for your prospective position as a CNA, LPN, or RN. Please put your name on each item. These will be de-identified and the researcher will keep a private list of staff completing these items. Turn your test into the DON or DON Dropbox prior to proceeding to the video. Following the completion of this video, you'll understand why chronic pain assessment is important. You'll be able to discuss misconceptions of chronic pain in the elderly, identify objective signs of pain, relate how cognition affects pain assessment. You'll be able to choose a pain assessment tool. You'll be able to accurately use the numeric rating system and Pain AD pain scales, and there will be interdisciplinary approaches to chronic pain identified. Chronic pain assessment is important for several reasons. Notably, chronic pain is quite expensive. The cost of chronic pain exceeds the individual costs of cancer, heart disease, and diabetes. There are also a number of consequences of chronic pain, including depression, disrupted sleep patterns, decreased mobility, altered gait and falls, and impaired ADL functioning. Additional consequences of chronic pain are reduced nutritional intake, social isolation and reduced will to live, decreased quality of life, increased dysfunctional or disruptive behaviors, weakened immune system, and further cognitive decline, leading to increased care demands. There are a number of misconceptions of chronic pain in the elderly. These misconceptions affect the assessment and management of chronic pain. Some of the common misconceptions are the belief that it is normal for people to have pain when they get older, older adults perceive less pain than younger adults, and that older adults are complainers. There are a number of objective signs to identify pain. The first is breathing. Occasional labored breathing is observed as periodic bursts of harsh, difficult, or waning respirations. Hyperventilation is rapid, deep breaths that last a short period of time. Labored breathing is negative sounding respirations when breathing in and out. It may be loud, gurgling, or wheezing. It appears strenuous. Long periods of hyperventilation is an excessive rate and depth of breathing, lasting considerable time. Cheyne-Stokes respirations are rhythmic waxing and waning of breathing from very deep to very shallow respirations with periods of apnea. Another objective sign of pain is negative vocalization. Occasional moaning or groaning can be mournful or murmuring sounds, wails, or laments. Groaning is characterized by louder than usual, inarticulate, involuntary sounds, often abruptly beginning and ending. Low-level speech with a negative or disapproving, muttering, mumbling, whining, grumbling, or swearing in a low volume with a complaining, sarcastic, or caustic tone. Repeated, troubled calling out is characterized by phrases or words being used over and over in a tone that suggests anxiety, uneasiness, or distress. Loud moaning or groaning is mournful or murmuring sounds, wails, or laments in much louder than usual volume. Loud groaning is characterized by louder than usual, inarticulate, involuntary sounds, often abruptly beginning and ending. Crying, or the utterance of emotion accompanied by tears. There may be sobbing or quiet weeping. Facial expressions can be an objective sign of pain. If they appear sad, an unhappy, lonesome, sorrowful, or dejected look, there may be tears in the eyes. They could be frightened, a look of fear, alarm, or heightened anxiety. The eyes appear wide open. Could be a frown, downward turn of the corners of the mouth, increased facial wrinkling in the forehead and around the mouth may appear, or facial grimacing, a distorted, distressed look. The brow is more wrinkled, as in the area around the mouth. Eyes may be squeezed shut. Another objective sign of pain is body language. The person could be tense or characterized by a strained, apprehensive, or worried appearance. The jaw may be clenched. They could be distressed pacing, activity that seems unsettled. There may be a fearful, worried, or disturbed element present. The rate may be faster or slower. The person could be fidgeting, which are restless movements. Squirming about or wiggling in the chair may occur. The person might be hitching a chair across the room. Repetitive touching, tugging, or rubbing of body parts can also be observed. They may appear rigid or stiffening of the body. The arms and or legs are tight and inflexible. The trunk may appear straight and unyielding. This does exclude any known contractures. Other body language that could be objective signs of pain are fists clenched, their tightly closed hands. They may be opened and closed repeatedly or held tightly shut. They may have their knees pulled up, flexing the legs and drawing the knees up towards the chest, an overall troubled appearance. They could be pulling or pushing away, resistiveness upon approach or to care. The person is trying to escape by yanking or wrenching him or herself free or shoving you away. They could be striking out, hitting, kicking, grabbing, punching, biting, or other forms of personal assault. Lastly, an objective sign of pain could be their ability to be consoled. They may be distracted or reassured by voice or touch. It's characterized by a disruption in the behavior when the person is spoken to or touched. The behavior stops during the period of interaction with no indication that the person is at all distressed. Or they may be unable to be consoled. They may not be able to be distracted or reassured. It's characterized by the inability to soothe the person or to stop the behavior with words or actions. No amount of comforting, verbal or physical, will alleviate the behavior. How cognition affects pain assessment. Residents with cognitive impairments are at increased risk for underassessment and treatment of pain. According to Apinas et al., 2/3 of residents have dementia, and of those, 50% cannot communicate because of severe impairment. Cognitive impairment may influence resident perceptions of pain and pain severity. There are cognitive impairments increase, nurses were less likely to document pain. As cognitive impairment increases, pain is often expressed in the form of behavioral disturbances. Memory loss may prevent the resident from remembering that they had pain and what caused their pain. Cognitively impaired residents are dependent on the observational skills of nursing providers to identify pain and needs that are no longer able to express for themselves. At this time, I'm going to go over a practice case study for CNAs. During morning cares, you are helping Mr. B transfer from wheelchair to toilet. Sitting in the wheelchair during upper body dressing, Mr. B grimaces as he lifts his right arm to put on his shirt. After dressing and toileting, you are helping him to come to a standing position to pull his pants up. As he reaches out to grab the walker, you again notice that he grimaces. What signs would lead you to believe he might be having pain? As we learned previously, grimacing can be an objective sign of pain. Mr. B grimaced when he lifted his right arm to put the shirt on, and he again grimaced when he went to reach out for his walker. At this point, CNAs can stop the video and complete the test. This is the same test you completed prior to this education. Again, put your name on the test and this will be kept privately. Please complete it and place it in the DON's box. CNAs may stop the video at this point. If LPNs and RNs could please continue watching. With RNs and LPNs, we're going to discuss choosing a pain assessment tool. The licensed nurse will screen each resident for pain using either the numerical rating system or the Pain and Advanced Dementia Scale. If indicated, based on their BIM score, the pain is treated using non-pharmacological and pharmacological interventions as per their resident's order listing. The licensed nurse will complete a timely follow-up of any pain treatment using the NRS or PAIN-ADS scale per the resident cognition and document the findings in the EMAR and nurse's notes. The indicated scale for each resident is based on their BIMS, is indicated per individualized plan of care. The numeric rating scale, or NRS, is a standard scale that utilizes 0 to 10 verbal pain ratings, where 0 is no pain and 10 is the worst imaginable pain. The resident will rate their own pain using the scale. The nurse attempts to use the NRS for all residents as most definite assessment of pain. The Pain and Advanced Dementia scale is utilized for nonverbal observation. It uses 5 items for observational tools. The staff can objectively measure pain based on observations. The PAIN-AD scale is used for residents with a BIMS less than 8. To use the NRS scale, you'll document the numerical value indicated by the resident. 0 is no pain, and 10 is the most excruciating pain imaginable. We will evaluate the pain intensity over time to determine the effectiveness of pain treatments and the need for changes in treatment. We'll ask history questions for a comprehensive pain assessment. Pain is treated based on the resident's tolerable level of pain. We would use the PAIN-AD scale on any residents that are unable to correctly use the NRS scale. We'll additionally be using this scale for all residents with a BIMS less than 8. Their BIMS can be found on their MDS tab under Section C. The number should be 0 to 15, and for this project, any patient with a BIMS 8 or less, we will be using both the NRS first and then the PAIN-AD scale. This scale was designed to assess pain by looking at 5 specific indicators. It has a cutoff score between 1 and 2, and it most likely represents pain in patients with dementia. A score above 2 probably represents pain in almost all patients and is most likely the cutoff value with optimal sensitivity and specificity, meaning residents with a score of 1 and 2 should be considered for pain treatment, and residents with a score of 2 or higher almost definitely need treatment for their pain. We'll observe the patient for 5 minutes before scoring their behaviors. The score the behaviors according to the following chart. The definitions of each item are provided on the following page. The patient can be observed under different conditions, such as at rest, during pleasant activity, during caregiving, etc. To score the patient's pain using the PAIN-AD scale, we first observe their breathing. They'll receive 0 points for normal breathing, 1 point for occasional labored breathing or short periods of hyperventilation, and they will receive 2 points for noisy labored breathing, a long period of hyperventilation, or Cheyne-Stokes respirations. We did define those above, but they can be found on the right for further review. Next, we will look at negative vocalizations. They score 0 points for none. They would get 1 point for occasional moan or groan or low-level speech with a negative or disapproving quality. They would receive 2 points for repeated troubled calling out, loud moaning or groaning, or crying. We would then look at their facial expressions, and they would receive 0 points for smiling or being inexpressive. They get 1 point for sad, frightened, or frowning. They would receive 2 points for facial grimacing. Next, we would look at their body language. They get 0 points for being relaxed, 1 point for being tense, distressed, pacing, or fidgeting, or they would receive 2 points for being rigid with fists clenched, knees pulled up, or pulling or pushing away or striking out. Lastly, we look at their consolability. They get 0 points if they have no need to be consoled, 1 point if they are distracted or reassured by voice or touch, and they would receive 2 points if they're unable to be consoled, distracted, or reassured. Please note this is not a total for each category. They would be either the 0, the 1, or the 2, not an addition of each of those. And then we would go ahead and total the score for each category into one total pain score. The scores ranging from 0 to 10 points. Areas of a comprehensive pain assessment include asking the patient the following questions. The onset, when did the pain start? The location, where does it hurt? Duration, how long has it been hurting? We need to ask about characteristics. Is it sharp, dull, aching, stabbing? Is it intermittent or constant? Please ask about aggravating factors. What makes the pain worse? Or relieving factors. What makes the pain better? We need to identify timing. When does the pain occur? And frequency. How often does the pain occur? Lastly, we should ask about attempted treatments. What have they tried at home as far as medications or non-pharmacological treatments, such as ice or heat? Lastly, pain is best managed with an interdisciplinary approach. The nurse aides will assist in observation and reporting to licensed nurses of nonverbal signs of pain that they note during resident cares. The licensed nurse and interdisciplinary team periodically evaluate the pain assessment, treatment, follow-up, and resident cognition for changes to the plan of care. At this point, we'll complete a practice case study for RNs and LPNs. Mr. X is a long-term care resident in your facility. His primary diagnoses include dementia, obesity, hypertension. You want to know which pain scale would be most appropriate to use for routine assessment of his pain. Upon reviewing his most recent MDS, you see he has a BIMS of 12. Which pain assessment scale would be most appropriate? You are completing a routine pain assessment. On the MAR, the patient is scheduled to have a pain assessment using the NRS every shift. You know the primary diagnoses are osteoarthritis, diabetes type 2, and major depression. You ask the patient to rate their pain using the NRS and they state 8. What is your recommended plan of treatment? What additional questions would you want to ask them so you can document a comprehensive pain assessment and a progress note? Knowing that Mr. X has a BIMS of 12, we will use the NRS pain rating scale. On the second, we'd want to perform a comprehensive pain assessment using the acronym OLD-CARTS, which we discussed above. This is onset, location, duration, characteristics, aggravating factors, relieving factors, timing, and frequency. We need to determine their tolerable level of pain and treat for pain according to their plan of care. At this time, I'll ask LPNs and RNs to please complete the test again that we did prior to the education. Please include your name, as this will be kept private by the researcher. Turn your test into the DON. Pre and post tests will be compared for increase in knowledge. Thank you.